Hi everybody, and welcome to our webinar this evening on testing and screening for Fragile X, IVF and PGD, presented by Dr. Mark Livingstone from Genea. So I'll hand over now to Dr. Mark Livingstone.
Hi everyone, and thank you for joining us. So we're going to talk about pre-implantation genetic diagnosis. So I'm a fertility specialist. I'm not a geneticist, and my main role is fertility treatment. But as part of that, I also do IVF as one of the treatments, and for people who can't get pregnant and people who have genetic conditions in the family or at risk of a child with a genetic condition. So we call that umbrella for testing embryos pre-implantation genetic diagnosis, which is really a test to differentiate embryos from those that will have a genetic condition and can be that won't be transferred to the uterus, and those that don't have the genes. And we do this for lots of different reasons. So more routinely now, we're actually testing embryos in people who don't have a genetic condition to just check the chromosomes, to check they've got 46 chromosomes to reduce the risk of miscarriage or chromosomally abnormal pregnancies. We don't do it for everybody, it depends on age and history, but we discuss it with I discuss it with all patients now because it is an option, whereas when I started doing this nearly 30 years ago, it wasn't the same and we weren't offering these tests. So just to try and reduce the risk of miscarriage, chromosomally abnormal pregnancies, which is to do with the number of chromosomes in the embryo, which is aneuploidy, or sometimes there might be a rearrangement of chromosomes called a translocation. So that's one of the tests we do. The second thing is to do genes-based testing. So looking for DNA issues, such as Fragile X, cystic fibrosis, spinal muscular atrophy. And also in the past, although I've not done it for a while, is HLA matching, which has been done to test embryos to look for those who might be able to use cord blood in a case of a sort of hematological condition that a child might be affected with. I haven't done that for a long time, or to test embryos to avoid an embryo that would not be inheriting that hematological condition. If we're going to do a pre-IVF assessment or fertility assessment, it's actually the same for someone doing fertility screens as well as for genetic testing of embryos. So the way I point out to patients the tests we need to do are, there are 4 things we're after. Is there sperm? Is someone ovulating? Not so important when we're doing genetic testing because we can induce ovulation with the drugs we use. Is there a normal uterine cavity, any polyps or growths or anything that could stop an embryo sticking? And are the fallopian tubes open? Now, if we're going to do IVF, we're not so much worried about the ovulation. We're not so much worried about the fallopian tubes because we bypass them, but we still need to do an ultrasound to check the uterus is normal. We check follicle numbers with that, which I'm going to come on to in a second. We do a sperm analysis to check we've got sperm and that the man actually has some sperm. We do chromosome tests to see that the man and the woman both have 46 chromosomes, XX for woman, XY for man, and that test takes about 4 weeks to get the results back. And I offer all of my patients the option of recessive genetic screening, and that's what's changed over the last few years a lot more. People are choosing the free test that Medicare brought in November of 2023. Before that, patients had to pay for all of their recessive testing. But Medicare brought in testing for 3 of the commoner conditions, Fragile X, cystic fibrosis, and spinal muscular atrophy in November 2023, to give people the option of screening for those conditions. And the female is screened, and the man is only tested if the female is positive for one of those recessive genes. But I do also offer an option for about 600 or 700 different recessive genes, which is a much more extensive screen, which does cost about $1,400 per couple, to see if there are any other rarer genetic conditions that they both share. And obviously, if a couple have a gene for the same genetic condition, then 1 in 4 babies are going to be infected, and we can do the IVF to test those embryos. So these are the screens that are offered to everyone. If someone's coming to see me who's knows they're at risk of Fragile X, I will offer them the more extensive screen, because sometimes we might find another gene there and we could end up testing for 2 things in the embryos. And if we're going to go ahead and do this, there is a workup to test, to work up the test for the embryos. It's not something we take off the shelf. And it's worked up per couple with family members as well. I once had identical twins come through. And when the second twin came through to do IVF to test embryos for the genetic condition that they both carried, she said, oh, well, I wouldn't need the workup. My sister has already been through. But because she had a different husband, we had to do a workup because it wasn't exactly the same genetics. So that workup costs around about $800 and can take about 10 weeks to develop. So when we're doing these tests, the Fragile X screen, we are picking up people, as you're all probably aware, who will be in the normal range, less than 45 of the CGG repeats, intermediate range, 45 to 55, 55 to 200, the premutation carriers. So the people sort of 60 to 80 are the people who might be having issues with fertility, with reduced ovarian reserve, because with the premutation carriers, they do tend to have less follicles and less ovarian reserve. I might move on to the next one. I think I've got a picture of an ovary on the next one. No, I don't. So as you know, people with the 80 to 100 CGG repeat range are the highest risk of ovarian dysfunction, not ovulating, running out of eggs. And these people will have less eggs with assisted conception. The test that we look at is ovarian reserve testing before doing an IVF cycle. So I want to get an idea how many eggs someone's going to produce when they're going to do IVF, genetic testing, or any assisted conception. And the way we do that is by doing an ultrasound to look at the size of the ovaries on ultrasound, to count the number of little follicles we can see on that ultrasound, and an AMH egg counting blood test. People with big chunky ovaries on ultrasound, lots of little follicles, and a high AMH blood test have got more starting on day one of a cycle than the reverse, who've got less starting there. From a natural perspective, it doesn't matter. It doesn't matter whether you've got 50 follicles starting on day one, because one gets bigger and releases an egg usually, and the others disappear. That's why women ovulate one egg, have one baby, and don't go on and have 50 eggs and 50 babies, thank goodness. The other ones are just lost and disappear. So as a woman gets older, there are less of them actually starting the cycle. It does matter for me and the patient doing assisted conception, because we give a drug called follicle stimulating hormone, and that's injected into the tummy. And a typical process would be 9 days of that injection from days 1 to 9 of the cycle. Just a dial-up pen, little bit of fluid, doesn't sting too much. And that follicle stimulating hormone is to make all the follicles that are starting on day 1 keep growing. So if you've got 50 starting there and one gets bigger and releases an egg naturally, we can now make 50 grow with the drugs. If you've only got 2 starting there and one gets bigger each month, you can still have a regular cycle, still get pregnant. Doesn't affect natural pregnancy rates, but it does mean a lower number of eggs when we do IVF. And that's the important thing with people with premutation carriers. A lot of them do tend to have the lower AMH, smaller ovaries, and less follicles. And a lot of patients therefore have less eggs, and that gives us less to work with. Doesn't mean it can't work, but it does mean less eggs, obviously, to start with when we do the cycle. So I do that to give me an idea how many eggs we're going to get, but it wouldn't tell me if someone was going to try and get pregnant naturally, how quickly they get pregnant, quality of eggs, who's going to get pregnant, or any of that. It's just a numbers scenario to tell me the quantitative number of eggs that we might get when we do IVF. Oh God, I've gone ahead, sorry. I was also going to say, when we're going to do, before we go on and do a cycle, I will liaise with my genetics colleagues, and they will advise someone who's suitable to go ahead and do the IVF and the testing of the embryos. One thing that we look at is the number of CGG repeats and also the AGG interrupts to determine what test should be done and what testing we're going to do during the cycle. If you've got more AGG interrupts, so 2, 3, 4, then it's less likely that that gene is going to expand. mutation is going to expand. Then there's less risk of an embryo being affected. So with IVF, I've explained the 9 days of injections, blood test, day 1, day 4, blood and scan, day 8, day 9. Usually done between about 7 and 9 in the morning, so as people can head off to work, get their results at lunchtime. Once these little follicles, where the eggs come from, get to about 14 to 20 millimeters in diameter, and you've got a whole group of them, that's when we think they'll have an egg inside them. We can't see the eggs. The eggs are 1/10 of a millimeter. But that's when we say, right, if that was today, day 9, they're good sized follicles, have a special trigger injection tonight, and we're going to collect your eggs 2 days later. So if it was tonight, you were ready, it would be Thursday, we'd be doing the egg collection. And we have the trigger injection 36 hours before the egg collection, because the eggs would pop and burst on about 39 or 40 hours after the trigger injection. So we go and get the eggs when they're nice and ripe and mature, just before they pop. So an 8 o'clock trigger tonight would be an 8 o'clock egg collection on Thursday. And this is what the follicles look like on an ovary. So you can see on the left-hand screen, there's an ovary with a natural ovulation. One big circle, which is the follicle, that's around about 18 millimeters, has a tiny egg inside it that will then pop and go into the fallopian tube. On the right-hand side, you can see someone who's been having FSH injections, and the follicles, there are a number of follicles there. So we measure them, and that's how we know when they've got to that 14 to 20 millimeter size and when we've got to go ahead and do the trigger. Now, the egg collection, this is a bit of a diagram of how we do egg collections. And you can see on the bottom, on the left-hand side, inside the vagina, there's a white probe. That's an ultrasound probe. And it lets me see the ovary just a little bit in the distance. And you can see all of the little follicles, and just puncture each of the little follicles delicately and drain all the fluid into test tubes. And then the scientists look through the fluid, might go on to the next slide, and pick out the eggs. So this is one of our rooms where we do procedures. You can see there's a nurse, there's a doctor, a patient, and a scientist, an embryologist on the right-hand side, looking inside a crib to look through for the eggs. There's a TV screen. People can look at the eggs on the TV screen and see what we're doing as we collect them. There is a partner there holding a hand, but we've stopped bringing partners in now because they kept falling on the floor and fainting, and then we had to look after them instead of looking after the person having the egg collection. So we have partners in for embryo transfers, but we stopped doing the partners for egg collections. With COVID, actually, that's when we actually stopped having people in, and we realized it was actually going much better. So we've reverted that. Now, I do a lot of egg collections awake with painkiller and local anesthetic in the top of the vagina, and people are amazed at how little they actually feel doing it. It's more uncomfortable afterwards rather than during the procedure. But people can choose to have an anaesthetist give them heavier sedation, which is a more common technique amongst the other clinics. So about 15-20 minutes, recovering outside, have a cup of tea, chocolate biscuit, and then usually an hour later on your way home, and taking that day off, maybe the next day off work, but most people are fine after a couple of days. A bit of discomfort, a bit bloated. And painkillers, of course, are important. And after the egg collection, we also recommend lots of fluids to keep people well hydrated. And I was just going to show the slide of ICSI. So this is us. We've collected the eggs. They're in the lab, and about 4 hours after the egg collection, timing things how it would be if the ovulation had just happened. Remember, we went in about 3 or 4 hours before egg collection. We get the eggs, we strip the cells from around the outside, and we actually inject a single sperm directly into the egg. We only want one sperm and one egg when we're going to do testing for a genetic condition, because we don't want any other sperm contaminating the outside of the egg and affecting our results. So you can see here, this is just a video of ICSI. So what we do is we have to knock the tail off the sperm. So this is a scientist going to do this. And once it's immobilized, we suck the sperm up into the pipette and then inject that sperm directly into the egg, which you can see here under a very high-powered microscope. And you see the sperm being dropped off. And that's the technique called ICSI. That's the thing we see on TV all the time. It's not usually relevant, but just makes good television when they've got the news on. But that's what we do for all of our IVF PGD cycles. This was actually discovered by accident in 1992 because a scientist, we used to inject the sperm just under the shell of the egg, and he made a mistake and went too far. And then when they realized that it fertilized, it revolutionized male factor infertility and lifted success rates dramatically. So it was discovered by accident. So one sperm, one egg. The next thing we've got to look at is the next day to see if we've got fertilization. So if we triggered today, egg collection Thursday, on Friday, we'd be looking to see how many of those eggs have fertilized. And we look at our embryos in time lapse in the lab. So if we had 20 follicles on ultrasound, not all of them will get big. We might get 12 eggs. When we put the sperm with the eggs, we might get 7 of them joined together and fertilize. And then we grow them through in the lab to day 5 and day 6, which is when we can do the testing and the biopsy. And we might get 2 or 3 embryos making it to that stage. And we actually developed these Genea incubators, which we actually sell around the world with our own culture medium. And you can see the embryo developing here, changing from 2 cells to 4 cells to 8 to a ball of cells called a morula. And now there's a blastocyst. There's an inner cell mass around about. There's one part that forms the baby, the inner cell mass, and the rest of the cells around the outside form the trophectoderm, the placental cells. And when we're going to do testing, we only check the placental cells. We don't touch the parts that would form the baby. So we have to make a little hole in the shell with a laser. We might go on to the next one. You can see the cells bulging out of that embryo there. So this is just a schematic picture of the same thing. You can see the embryo at day 5 or day 6 down on the bottom part of the slide, just showing this embryo's pushed a whole load of cells out of the little escape hatch, the hole we've made inside, so that we can chop off some of those cells and do testing for chromosomes and also checking for the fragile X. Now, go on to the next one, please. Patients can now watch their embryos. So we have an app, and we developed this quite a long time ago, so that patients can actually watch at the end of the day. This embryologist will send a patient an update. Day 1 to show the number of fertilized embryos and get pictures of each of your embryo. Day 3 and day 5 and day 6. So you can see pictures of how they're developing through the lab. And we just got, and that's called Grow by Genea. So we've had quite a lot of technological advances over the years. Because I've been there a long time, I've seen a lot of things change. Our success rates dramatically improved in the early 2000s because we changed from having all the embryos in one incubator to their own individual incubators, because we realized that every time we opened the door, the temperature was dropping inside the incubator and it was affecting those that were in there. Once we changed to their own incubators, that really helped us give us the edge over other clinics and lift our success rates. And then there's been a lot more innovation, as I said, with the special Genea incubators to do the time-lapse photography, the special culture mediums that we've developed over the years. And then we've got technical things like the Grow by Genea. And we also have, I'll come to that in a sec, sorry. Go on to the next one. I'm getting ahead of myself there. Now, if we've got embryos to biopsy, they've got to make it to that day 5 stage. We've got to chop off those cells, and we've got to freeze. And we've got to wait for a few weeks for results to come back. So the workup's all done, the 10-week workup. We know we've got a test to go. And the cost of testing embryos is about $950 per embryo, capped at $3,000 for 5 or more. So if there's 10 to test, it's not $9,500. We also, a few years ago, Medicare came to the party and are now paying a rebate for up to 3 embryos in each cycle. So the first 3 embryos are about half price, about $450 per embryo. and then the next two are $9.50, and then the rest above that, there's no charge at all. Standard testing is now karyomapping. That's our standard one. And I've got a picture here of something that happened with a patient who had 29 repeats on one X chromosome and 76 repeats in the premutation range on the second chromosome. And the testing for karyomapping is to check the chromosomes to see there are 46, there's not an extra one or one missing, and also to look at the X chromosome that's been inherited from the parent. So you can see here our parents. We have the female on the left side with 2 X chromosomes, a yellow one at 29 and a red one with 76, which is a premutation with the CGG repeats. And on the right side, we've got the man who's got an X and a shorter Y chromosome. You can see the darker blue is the Y chromosome. When we look at the embryos, we're looking to see which ones will not be affected. And you can see that a non-carrier female has inherited a 29 in the man's X chromosome. An affected female has inherited the 76, the red one, in the man's chromosome. A non-carrier unaffected male has inherited the 29 and the Y chromosome, the dark blue. And then the right-hand side, the affected fragile X male has inherited the Y chromosome from the male and the red 76, the longer. That's a likely affected male. So that's the results we had. So looking at those, you're looking at 50% of embryos could be used and 50% of embryos could not be used based on that testing from the karyomapping, provided those are chromosomally normal. Chromosomally normal members, and that's the results we will get initially. Now, our very clever PGD scientists have actually developed a test now to not only look at that, but in certain patients to do a direct test on the embryos. So not just to look at those that could be affected, not affected, but just like you have a test to look at CGG repeats, we can now look at embryo CGG repeats to see if it's expanded or not. And so that's now a direct test, which is secondary to the karyomapping to identify those at risk, and also to look at the chromosomes as well. Now, not every patient is suitable for direct testing. So we don't need to check the CGG repeats in every embryo. If someone is very lucky and has 5 unaffected embryos, they may not want to do this direct test because it's an extra workup, it's extra money, and we hope they don't need to do that because we hope one of the 5 that are not at risk will work, and then they'll be able to complete their family. Any embryos over 180 repeats are classified as affected. Embryos with less than 180 repeats are classed as at-risk premutations after we've done the testing. So we look at the CGG repeats, we look at the AGG interrupts with the geneticists, and we work out certain patients are appropriate for this. And we've actually got a bit of a graph where we say, do the test, don't do the test, or not suitable. So there's a sort of graph that we use. And it depends on the AGG repeats, because if somebody has 60 repeats and a lot of interrupts, they're not a high chance of passing this on, of expansion, shall we say. If they've got 60 repeats and no AGG interrupts, then we might recommend doing this direct testing. So it depends on the results which way we go. And we get results to tell us the sex, and we aim to go for female embryos, because if there's a problem with the test, then there's less risk of an issue if there's been an issue with the test, because nothing's 100% with the testing that we do. We often quote 99% for the gene issue, the fragile X, and about 90% accuracy for the chromosome testing. So you can see here, we've got someone here, very similar story, 29 and 84 on the female side, so an X chromosome that's got the normal CGG repeats and the premutation carrier, and on the right-hand side, the male. And these are the results from 5 embryos that were tested. you can see that there are 2 males and a female that are fine. They've inherited the yellow 29X chromosome. We can see 2 embryos that have inherited the 84, and we need to know whether we can use any of those embryos. Has it expanded or has it not? That's basically what we're doing with the direct test. Before we had this test, we probably wouldn't go ahead and use those. We would just say we're not going to use those embryos unless there's a lot of extensive genetic counseling and someone decided to go ahead, or it was deemed to be a lower risk if there's a lot of AGG repeats. Or interrupts, so we say, sorry. With regards to the testing here, you can see the 2 on the left and the right have had extra direct repeat testing, and the one on the left has gone to 90, so it's not expanded, and on the right has expanded to over 200 and can't be used. So it's allowed us another embryo to use that wouldn't have been available beforehand, and that's the purpose of doing this testing. All right. Now, before I talk about embryo transfer, I was going to talk about other clinics are not able to do this. So I don't think many clinics around the world are able to do this testing. There may be other ones, but I've recently had someone bring 3 embryos across from another clinic who they'd been told they couldn't use these embryos because they hadn't had the direct testing, and we're actually waiting for the results to come back to see if any of those 3 that are in the freezer could be actually used. And one of the issues, as you remember when I first started talking, was we were concerned about not having a lot of eggs, not having a lot of embryos. And so every one is precious, especially in patients with Fragile X. So transfer of the embryo is the easy part. It's like a pap smear. In a natural cycle, we do blood tests, day 10, day 12, day 14, to see when someone's going to ovulate. And 5 days later, we thaw the embryo and pop it back into the uterus like a pap smear. So if you ovulated today, embryo transfer would be on Sunday. And yes, it does happen on Sundays. I worked last Sunday because whatever day you're ready is the day we do your procedures. A lot of other clinics might just do Monday to Saturday, but we do whatever day is the right day for you. So only medicine you'd need would be a progesterone pessary every night for 3 nights before the transfer and about 11 nights afterwards. Just a little pessary you pop inside the vagina just to boost progesterone levels. So it's a lot easier to do the transfer, and that's why it's good when we do an IVF cycle to use the drugs to try and get a good number of eggs, to try and get a good number of embryos and do it once rather than do it twice. But of course, that is one of the issues with Fragile X is you can have to use higher doses of medication, and above a certain dose, it's not going to have any effect. It's a bit like taking 10 Panadol for a headache. Above a certain dose of stimulation, you're not going to get, any more eggs. After an embryo transfer, people can go home straight away. And basically, we do the pregnancy test about 11 days later. So from today, it would be a week on Saturday for pregnancy test. And I talk to everyone on the day of pregnancy test, be it a positive or a negative. And if it's positive, it's an ultrasound scan 3 weeks later. So it'd be 4 weeks pregnant with the pregnancy test and 7 weeks pregnant when you do the scan 3 weeks later. So that's just talking about luteal phase. Yes, that's the same thing as just talked about. So we have a lot of people working in the team. I have talked about the geneticists and the genetic counselors, which are really crucial for counseling with this and advising which way we should go with direct testing, etc. If someone comes to see me, I do all the tests, assess them for assisted conception, refer on to the geneticist, refer on to the patient relationship coordinator, who's someone who discusses how much it costs, how much rebates are, books in for a nursing interview so as the nursing staff can explain where bloods are done, where ultrasounds are done, how you phone up for results, all the sort of day-by-day running of a cycle. And the cycle data is given usually by voicemail, over the phone, and of course nowadays with an app, because everything has an app. And that's how people like to get their information. It doesn't disturb them at work if we're giving them all the instructions and information. There's the embryologists, as I pointed to in one of the pictures, the people who actually collect the eggs and get the embryos ready for biopsy. The PGD team who do the testing, and the andrologists, they get the sperm sample ready. So there's a lot of people involved. There's also an emergency number if there's an issue, sort of 24/7. We have an ex-nurse who moved to the UK who's on call Monday to Friday with the phone because it's really handy that she's in a different time zone. So she's on call all the time for any issues during the night, if there's any issues. Oh yeah, I thought I was done. Yeah. So that's me sort of giving you a brief overview of how it works. But the summary for an egg collection cycle, I explain 9 days of injections, 2 or 3 early morning bloods and scans, egg collection about day 11 with a day off work and someone to take you home. Waiting to day 16, 17 of the cycles when we get the embryos to biopsy. And of course, we've got to get stimulation. We've got to get eggs. They've got to fertilize. They've got to make it to that day 5 stage. We then biopsy and freeze and wait 3 weeks for results to come back. And when we get the results, there's a small chance we might not get a result from the embryo. It's about 10% chance of no result because we're dealing with really tiny amounts of genetic material. It's got to be the result we want. We've got to decide if we're going to do the direct testing, depending on what we've got in the way of embryos and what the results are on the Fragile X mutation results. And then the embryo's got to survive defrosting. Unfortunately, there is about a 3 or 4% chance that the embryo will not survive defrosting. And when we put it back into the uterus, it's about a 50-50 chance of success. So even with a chromosomally normal embryo that's unaffected, it's not a guarantee it will result in a pregnancy, I'm afraid. So that's me giving you a little insight into that. Cost-wise, because I'm Scottish, so I like to give you the numbers. It's around about $15,000 at the beginning of a cycle, get about $5,000 back from Medicare, $2,000 back from health funds if they cover you for IVF. So you're looking at around about $7,000 or $8,000 out of pocket just to have the embryos collected and biopsied. By the time you get result, by the time you biopsied 3 or 4 embryos and got results, you may be around about $10,000 or $11,000 out of pocket. And we haven't used any yet. We could have no embryos available for use and have to start again. So it is an expensive process embarking on this. As you can imagine, all the sort of technology and the things that have been developed to do this, it does cost a little bit of money. And that's doing procedures 7 days of the week. Whichever day you're ready, we do the procedures, and I talk to everyone with PGD results. So when the results come back from the embryos, I give those results personally to patients. A lot of other doctors leave it up to the scientists, and I talk to people on pregnancy day as well because I want to give people the results. So that was a lot of talking, but I thought I'd give you a bit of an overview on what was involved with IVF and sort of just link it to the Fragile X as well.